class, I think what I'll do now is talk about problems with the oversecretion of hormones in the adrenal medulla of norepinephrine and epinephrine. And these are usually caused by what we call a pheochromacytoma, okay? I'm going to talk about pheochromacytoma, and then I think I'll do hyperaldosteronism, and then the rest we'll conclude with in class on Tuesday. I'd really like to do the adrenal problems of Cushing's and Addison's in person because those are a little bit more complex and I want to go over things with you. A pheochromacytoma is basically a tumor of the adrenal gland. Produces excessive amounts of adrenaline. Usually pheochromacytomas arise from the central portion of the adrenal gland, which is called the adrenal medulla, okay? I'm so sorry about my dogs barking, so I apologize. Hopefully they don't bark anymore as I continue to talk about pheochromacytoma. It's usually benign and can happen at any age, but usually 40s to 50s, men, women equally. 10% are bilateral and about 10% are malignant. Most of them are just benign. It can be a familial tendency, and about 8% of these tumors are asymptomatic, okay? Remember, if you go back to the adrenal medulla and kind of think about what hormones come from that portion of the adrenal glands, they are responsible for the normal production of adrenaline, which our body requires to help maintain blood pressure and to help cope with stressful situations. They basically are pretty rare. They're usually from an adenoma on the adrenals. And as I said before, they usually aren't cancerous, but they can be associated with other cancerous tumors and other endocrine glands, such as the thyroid gland. And what it basically does is increases production of adrenaline and norepinephrine. It could release large amounts of adrenaline to the bloodstream after an injury or during surgery, or it can be precipitated by a physical, emotional, or environmental stimuli condition, which could be very life-threatening, okay? Our concern with this is, think about what epinephrine and norepinephrine do, okay? They're catecholamines, and they stimulate the central sympathetic nervous system, okay? And unfortunately, many organs are affected. Most dangerous effects are from the peripheral vasoconstriction and the increased heart rate and contractility, which eventually results in some kind of paroxysmal hypertension. And we're talking about blood pressures that are well over 200 or 300 systolic, with diastolics anywhere from 150 to 175. So these are just extremely high blood pressures, which absolutely can be very life-threatening, okay? The blood pressure may be intermittent or it may be persistent, okay? And our big concern is obviously with that high blood pressure, high heart rate, which also lead to episodes of sweating, headache, pale facial appearances, almost symptoms similar to those of extreme fright. And if this blood pressure is not treated or brought down, it could lead to some very serious consequences. Most of the symptoms are headaches, which can be extremely severe, excessive sweating, racing heart, tachycardia, palpitations, and extreme anxiety. They have this complete and utter feelings of impending death or doom, nervous shaking, pain in the lower chest or upper abdomen, can have nausea or not have nausea, weight loss, or heat intolerance. Sometimes with pheochromocytomas, it takes years to diagnose because epinephrine has a half-life of less than 1 second, and you can't diagnose it with a lab test. But you can diagnose it with history and with these VMAs, or 24-hour urine specimens. And vanillyl-mandelic acid is the end product of metabolism of all catecholamines. So this is why these VMAs can be detected in the collection of a 24-hour urine sample. Another thing that you want to think about when we're talking about a pheochromacytoma, obviously the tumor could be diagnosed by an MRI or a CAT scan also. But let me bring that down so you can see that in the view box. As you can see, VMAs. And make sure that you're collecting that properly, and how the patient has to be aware that they have to collect every bit of urine that is, secreted in a 24-hour period, okay? But another thing that you want to think about too is that remember, epinephrine and norepinephrine are counter-regulatory hormones. So your patients not only have hypertension, headache, hyperhidrosis, which is excessive sweating, hypermetabolism, but also hyperglycemia, okay? Because remember, the hyperglycemia may result from conversion of liver and muscle glycogen to glucose due to epinephrine secretion. And so these patients may need insulin in regards to the excessive secretion and excessive abundance of epinephrine and norepinephrine on board, okay? Some may have the paroxysmal form, which means it could be characterized by an acute or unpredictable attack lasting seconds or hours. It can begin abruptly or subside slowly. Again, characterized by anxiousness, tremors, weakness, headache, vertigo, blurring of vision, tinnitus, air hunger, and dyspnea. As I said, blood pressures really get extremely high. They're life-threatening. As a result, patients can experience severe cardiac complications such as dissecting aneurysm, stroke, or even acute renal failure. Remember, it's an overactivity of the sympathetic nervous system. So think of the 5 H's, okay? Hypertension, headache, hyperhidrosis, hypermetabolism, and hyperglycemia, all right? Again, diagnosed through blood and urine tests that reveal elevated levels of adrenaline and norepinephrine, the 24-hour urinary catecholamines, such as VMA, those end products of catecholamines, and again, CTs and MRIs that actually detect the tumor. The important thing to remember is that they're going to put these patients probably in ICU, and if they determine that they have to do an adrenalectomy or try to remove the tumor, they've got to get the patient stabilized before they actually take them into OR, because the patient probably will not survive, okay? So it's really important that they get the blood pressure down, okay? And really try to, get the patient in a more stable condition. They look in the patient's history to look for any stressors that may lead to this crisis. Again, no smoking, no caffeine, or even changing positions quickly to kind of stimulate the secretion of these hormones. It's very important that the abdomen is not palpated, because you can actually release the hormones from the tumor, from the area. important that they get enough calories, vitamins, and minerals. Obviously give beta blockers to bring down that heart rate. And it's very important that once the patient is stabilized and they're ready for surgery, that sometimes anesthesia agents and touching of the tumor during surgery can cause the hormones to secrete out. So that's why, it's really important to get that blood pressure more stabilized. Some of the tumors may be inoperable, so that's why what we can do is just treat these patients medically, okay? Excuse me. Many times it may take weeks to get them stabilized if they are going to go to surgery and they are a candidate to have the tumor removed. But a lot of times they're inoperable because of the patient's other medical conditions. These types of tumors do not respond well to radiation or chemotherapy. So that's why it's pretty inevitable that the patients have to have some kind of surgical intervention, okay? And that's why it's really important that we don't want to provoke a hypertensive crisis. So it's important that there's not increased abdominal pressure. Be careful when they defecate, and really avoiding vigorous abdominal palpitations. And even such drugs as tricyclic antidepressants, glucagon, metoclopramide can all induce a hypertensive crisis, along with some certain foods or even beverages high in tyramine, aged cheeses, red wines, cured meats. So those are things that, when we can finally make that diagnosis of a pheochromacytoma, we would encourage people to stay away from those types of foods that would precipitate the hypertensive crisis. Okay, so again, the 5 H's in regards to a pheochromacytoma. And remember, epinephrine is a counter-regulatory hormone. So, excuse me, and these patients too may be in ICU to better control their blood pressure and kind of get them out of that danger zone and getting that blood pressure down to a more acceptable range. Okay, so that's pheochromacytoma. All right, the next thing we're going to talk about is hyperaldosteronism. Okay, again, we've talked about aldosteronism, especially in reference to the renin-angiotensin-aldosterone system. Just think back where aldosterone comes from. It's the mineral corticoid produced by the adrenal cortex. Controls extracellular fluid, causes sodium and water retention by acting on the kidney tubules. That's the process involved in the renin-angiotensin-aldosterone system to increase blood pressure. Okay. There's a lot of situations that will cause an increase in aldosterone, okay, and one of them is hyperkalemia. When serum potassium ion concentration has a regulatory effect on aldosterone secretion, even patients that become hyponatremic, hypovolemic, we know that from being the trigger that kind of starts that renin-angiotensin-aldosterone system. All those situations will thus increase the secretion of aldosterone, okay? There's certain things that cause a decrease in aldosterone production. And so that's why it's so very important that we're always assessing our patients' electrolyte values, because with sodium problems and potassium problems, that could be the reason why a patient might be, holding on to more fluid, or having problems with acid-base balance or even potassium levels and things like that. So that's why it's really important when we talk about aldosterone, because really what we see happen with aldosterone is the process of, retaining sodium in water, thus increasing vascular volume. So that's why we're always looking at potassium levels, watching INO, patient's blood pressure, patient's weight, and also really assessing the pH of the blood, because acidosis will cause a decrease in aldosterone production. So when we talk about hyperaldosteronism, obviously we have too much aldosterone on board, okay? And primary hyperaldosteronism is also called Conn syndrome, C-O-N-N'(S) syndrome. And again, it's usually caused by a benign adrenal tumor, and it will reduce the ability of the kidneys to concentrate urine, okay? Secondary hyperaldosteronism can be caused by excess high levels of angiotensin II that are stimulated by increased plasma renin levels, because we know renin comes from the kidneys. That starts that whole process of the renin-angiotensin-aldosterone system, okay? So when a person has a oversecretion of aldosterone, it will affect the renal tubules, causing sodium retention with potassium and hydrogen ion excretion. So basically the manifestations of someone with hyperaldosteronism is hypernatremia, hypokalemia, and metabolic alkalosis, okay? So sodium and blood volume will increase. It will suppress renin production. And with that said, and with increased blood volume, obviously increased blood pressure, which puts the person more at risk for strokes or kidney damage, okay? Obviously with that increased blood pressure going up, patients will have headaches, fatigue, muscle weakness. We can diagnose it by lab studies, x-rays, and imaging, and looking at renin and aldosterone levels, okay? So again, to summarize, hyperaldosteronism is the increase of mineralocorticoid excess, and this comes from the adrenal cortex. So the patient is hypernatremic, hypokalemic, and may develop metabolic acidosis. So sodium retention results in fluid retention, causing hypertension. So we need to treat it with a low sodium diet and a potassium sparing diet. So we wouldn't treat it with Lasix, because obviously a patient who becomes who is on Lasix, we deplete potassium levels, and we would cause the patient to be hypokalemic, okay? And so that would not be the good drug of choice. We would definitely want to provide and administer a potassium-sparing diuretic like aldactone or spironolactone, which is an aldosterone antagonist, okay? So hopefully now it makes a little bit more sense about medications when we talk about that, because of its influence on aldosterone levels, okay? As I said before, with hyperaldosteronism, it can be caused by an adenoma or obviously higher levels of angiotensin II because of increased plasma renin levels. Affects the renal tubules to retain sodium and excrete potassium and hydrogen ions. So we know now how the patient presents, and so to correct this imbalance, the patient gets aldactone and low sodium diet, and we watch blood pressure. And because of the effect it has on potassium, we also want to watch for any signs of severe hypokalemia, which could cause cardiac arrhythmias, general muscle weakness, and of course metabolic alkalosis. So how we would treat this would be to remove the tumor or the cause of the oversecretion of aldosterone by doing a adrenalectomy, decreased sodium diet, and of course aldactone, okay, which will increase excretion of sodium water, and that will be a way to definitely hold on to that potassium and hopefully to decrease that blood pressure as well, okay. Sometimes if the tumor is only in one adrenal gland, and we call that a unilateral tumor, they may give, as I was saying, if it's a unilateral tumor, we may give glucocorticoids temporarily to prevent the patients from going into any kind of adrenal crisis. Many times they'll give glucocorticoids before surgery to prevent that adrenal crisis, okay? Watching for, signs of hypokalemia. They won't do surgery on the adrenals until blood pressure is under control and until potassium levels are normal, okay? And if both adrenals have to be removed, the patient obviously has to be on lifelong glucocorticoids to prevent any type of Addison's crisis. So that's basically where we're going with that. I think that really is about all when we're talking about hyperaldosteronism. Again, just think of what is occurring when we talk about the effects it has on blood pressure and the effects it has on sodium, potassium, and also acid-base balance, okay? So we want to control those because sometimes when these blood pressures get really high, patients may also start to develop visual changes. But again, we're watching for, any kind of problems associated with, low potassium levels and high sodium levels. So let me know if you have any questions, and that's pretty much it about pheochromacytoma and hyperaldosteronism.